Welcome to a new webinar organized by NEMUS, the Network for Multidisciplinary Studies on ARV-based HIV prevention. We are really pleased to have you here this morning when we're going to listen to Professor Jean-Michel Molina, who is going to present on PrEP in MSM and how data from the study IPrEG fit in this context. This is going to be one of the first, this presentation is about one of the, what we could call the first second generation regimes of PrEP, where something different from the daily pill regime has been studied, and fortunately it was a successful intervention and a very interesting study. So, but before we announce Jean-Michel, let me just mention that we're starting a second phase in NEMUS, in this project, in this initiative of a network. And in this phase, we're going to try to increase regional exchanges and participation. We are definitely going to try to work more in other languages, particularly French, Spanish, and Portuguese. And for that, we are going to partner with very valuable collaborators such as SIDACCION, the Pan American Health Organization, and the Ministry of Health of Brazil. In part, that will result in more webinars in those languages, we hope, because we recognize that language is a very important variable when we have to deal with discussions on policy, which tend to be very local. So that's something we'll try to do. But for now, Jean-Michel, whose primary language is French, is going to present in English, and we're going to have, I'm sure, very interesting discussion on that. So yeah, probably now we can try to start. As I said, the title of the webinar is PrEP in MSM, how data from IPrEG fit in the context. And to introduce Jean-Michel, I mean, for those who don't know him, because he's fairly well known, he's a professor of infectious diseases at the University of Paris Diderot in France, and head of the Infectious Diseases Department at the Saint Louis Hospital in Paris. In Paris, he's a principal investigator of the ANRS-IPERGAY trial assessing on-demand pre-exposure prophylaxis with TDF FTC in gay men, men who have sex with men, study that proved 86% efficacy with the use of this combination, this drug combination, for the prevention of HIV acquisition in MSM. His primary clinical research interest focuses on the treatment of HIV infection, resulting in his involvement in a number of studies assessing new drugs or strategies for the treatment of HIV infection and co-infections with HBV and HCV. In addition to his research responsibilities, he's chair of the clinical trials group at the French National Agency for AIDS Research, ANRS. So we're going to have this webinar today. He's going to present using PowerPoint, and if people have any question, I mean, there's a chat window on the right-hand side of your everybody's screen, so you can use that chat window. We're not using open conversation to avoid background noise, and this webinar is going to be recorded and uploaded, so it can be accessible to others later. So let me just turn the mic to Jean-Michel. Welcome, bienvenue, Jean-Michel. It's our pleasure to have you here today.
Thank you very much, Carlos. Good afternoon or good morning to everyone, and muchas gracias for inviting me to this web seminar. As you said, I'm going to speak in English, and hopefully in the near future I might also participate to web seminars in French. And again, thank you for your very nice introduction. What I'm going to try to do today is provide you with an overview of the data from the IPrEx study, but also review some of the recent studies on PrEP in MSM to put the data from IPrEx in the context of PrEP for MSM, a population that, as you know, is highly affected by the HIV epidemic. So I'm going to try to move to the next slide. Okay, that's it. So as you know, this slide is providing an overview of the global epidemiology of HIV infection in MSM. As you can see on the left-hand side panel, wherever you look in any countries or continent, you could see that the highest prevalence of HIV and the highest incidence rates have been reported in MSM as compared to the adult population, heterosexual adult population. And clearly, what we know, in particular in high-income countries, is that the HIV epidemic in MSM is expanding. So we have an issue also in high-income countries about the HIV epidemic today. We also know, and that's also one reason why we have such an epidemic in the MSM population, that there is a very high probability of transmission of HIV per act through receptive anal intercourse of 1.4%, which is on average 20-fold higher than through heterosexual intercourse. And finally, we know the challenges of the HIV epidemic in MSM because of the hidden and stigmatized MSM population in the different countries in the world. On the right-hand side panel, what you can see is the growing number of HIV infection in MSM in France over the last couple of years. And in the year 2013 alone, more than 6,000 new HIV infections have been discovered, and among them, 43% were diagnosed in MSM. So clearly, we have a major issue in the MSM population, also in France, and that's why we were interested in improving, prevention of HIV in this population and assessing new prevention methods, in particular PrEP. Before the data from PROUD and IPrEx were presented at CROI, the only trial assessing PrEP in MSM was the IPrEx trial, a trial you know very well, which was actually conducted by Bob Grant in different places in the world, in South America mainly, in Peru, Brazil, also South Africa, Thailand, as well as a few places in the US. And this trial was really the first to show the benefit of a daily pill with a combination of TDF and FTC, the Truvada pill, to reduce the incidence of HIV infection in gay men. And as you can see on this slide, in this trial, which actually enrolled more than 2,500 participants, after a median follow-up of 14 months, the incidence of HIV infection was reduced by 44% in those randomized to the FTC-TDF arm. And the incidence in the placebo arm in this trial was nearly 4 per 100 person years and was reduced to 2.2 in those receiving FTC and TDF. So this was the first evidence that PrEP could work, but some might say that this level of reduction of HIV incidence may not be as great as expected. And you know that the reason for that is because of the low adherence that was observed in the IPrEx study, especially when you looked at adherence assessed by the proportion of patients who had drugs detectable in plasma. With a daily regimen of TDF and FTC, we expect that all patients will have TDF detected in their plasma. But in fact, when they looked at a subset of participants in IPrEx, they found that only 51% had drugs detected in plasma, meaning that only half of them were probably able to fully adhere to these daily PrEP regimen. And that's probably why the efficacy was actually lower than expected. But if you look at what you could call adherence-adjusted efficacy, when you look at the efficacy only in participants who had drugs detected, then the efficacy actually increased to up to 92%, although this result is not a straightforward result as long as it is a post-hoc analysis, and therefore this analysis is not protected anymore by randomization. But that gives you an idea of how effective this regimen could be if people could fully adhere to this daily pill. And what you have also on these slides are the results of the other PrEP trial using the same daily regimen with TDF and FTC. And you see that according to the level of adherence measured by drug levels in blood, you have different levels of efficacy in the modified intent to treat analysis in those trials. And clearly the best results were obtained in the Partners PrEP study in serodiscordant heterosexual couples in Africa, and the worst results in heterosexual women in FemPrEP and VOICE, clearly with a very low adherence to the PrEP regimen. What's interesting is also when you look at all these studies and you look at adherence-adjusted efficacy, here you could see that consistently the efficacy in these study was above 70%, which gives you an idea of how effective this strategy could be if people could fully adhere to their regimen. Another way to look at the importance of adherence and the relationship between adherence and efficacy is to look at not anymore drug level in plasma, but drug level in PBMCs. And here looking at the level of tenofovir diphosphate in PBMC. If you again look at the IPrEx data in a subset of people, here 144 controls, in whom you measure tenofovir diphosphate in their PBMC, you could see that drug was detected in 64% of these people, and the median level was actually 16 femtomole per 10 to the 6 cells in the PBMCs. If you look at the cases, which are actually patients in IPrEx who received TDF and FTC, but who acquired HIV infection during the study, actually among the 42 cases, only 3 had drugs detected in their PBMC. And you can see that 93% had drugs below the level of quantification. And so when you do regression analysis in IPrEx, you could, according to these data, assume that you have nearly 90% reduction of the risk of HIV acquisition if you can achieve this level of 16 femtomole per 10 to the 6 cells in PBMCs with TDF and FTC. Another way to look at the data is to look at results from another study, the STRAND trial, which was conducted in healthy people, which were asked to receive Truvada either every day, 7 days a week, or 4 days a week, or only 2 days a week. And you could see that in those people who received Truvada only for a short period of time, only for a couple of weeks, all of them had drug detected. 0% had drugs below the level of quantification. And when you look at their median concentration of tenofovir diphosphate in PBMC, you could see that with 4 pills per week, the median concentration was above the 16 femtomole that you had in IPrEx. And you could calculate that the predicted risk reduction of HIV acquisition with this level of tenofovir diphosphate related to only 4 pills per week was 96%. And with 7 pills per day, if people are fully adherent, the level of tenofovir diphosphate that you achieve in PBMC would predict a 99% reduction of HIV acquisition. Another piece of data comes from a recent study done by the group in Colorado, looking at the timing of onset of inferred HIV risk reduction with Truvada. In this study, also conducted in healthy volunteers, people receive Truvada 1 pill per day for 30 days, after which the treatment was discontinued. And what people did in that study was first to look at the time at which people were able to achieve in their PBMC this level of 16 femtomole per 10 to the 6 cells. And actually, there was, after only 3 days, 3 daily doses of Truvada, there was a 96% potential reduction of HIV risk. And this reduction was approximately 99% after 5 days. And this gives you an idea of how soon with a daily regimen you will need to take the drugs before being fully protected from HIV acquisition. Also, they looked at the time during which you are also protected when you stop taking Truvada, and in those participants, the reduction of HIV risk was greater than 90% for the next 7 days after actually this discontinued Truvada. We also have data, PK data in healthy volunteers, and following a single two-drug track, the concentration in rectal tissue at the time and in blood plasma of tenofovir here on the top. And what was interesting was that the concentration of tenofovir that you can reach in the rectal tissue was actually on average 30-fold higher than the concentration found in blood, although you have to acknowledge that it is difficult to compare drug level in blood and drug level in rectal tissue. If you look at cervicovaginal fluid in the bottom panel, you could see that, again, the concentration of tenofovir was higher in the cervical tissue than in blood, but it was only 6-fold higher, so not as high as in the rectal tissue. But actually, the concentration of FTC, on the other hand, was much higher in the cervical vaginal tissue than it was in blood, and much higher than in rectal tissue. So it is really interesting to see that both drugs, whether you look at TDF or FTC, can concentrate pretty high in the genital tract, and higher probably than in blood. And that might explain why these drugs are very suitable for use for PrEP. Another piece of information comes also from the open label extension of the IPrEx study, when people looked at what people did with PrEP once the drugs were offered and people were no longer in a double-blind study. Interestingly, the majority of people opted to receive PrEP, 76%. But for those not requesting to use PrEP, it is interesting to underline the reason why people might not be willing to take PrEP. Half of them were concerned about side effects. A few were not happy with a daily regimen. A pretty sizable proportion preferred other prevention methods. And also a few were concerned about stigma. And that's true that with the early PrEP studies, people taking drugs for PrEP were stigmatized, and we probably have to do a better job to try to avoid that. It's interestingly also in this open label extension of IPrEx, the investigators were also able to show a decreased incidence of HIV infection in those opting to receive PrEP. The safety was also good, very few discontinuation, only one individual acquired HIV infection with 3TC FTC resistance. And interestingly enough, there was no evidence of risk compensation, which is a much feared, risk with PrEP. And whether you look at the use of condom, the incidence of syphilis, or the number of sexual partners, there was no evidence of risk compensation with PrEP in that study. And on the top of that, when they tried to assess the HIV incidence with drug levels, looking at drug level in dry blood spots, they were also able to show that, beyond a certain concentration here of 700 femtomole of tenofovir diphosphate per punch, there was almost no incident HIV infection. And this concentration is actually seen, according to previous studies, to the use of at least 4 tablets a week. And these data are interesting when we will look at the data from IPrEx. But before looking at the data from IPrEx, it is important to spend a few minutes to review the data from PROUD. And it is actually very important that the 2 studies were done together, and that together these results were presented and yielded the same very high effectiveness of PrEP in the intent to treat analysis. So as you know, the PROUD trial was randomized with one arm in gay men receiving immediate daily TDF and FTC, and the other arm receiving TDF and FTC, but only after 12 months. And actually, the inclusion criteria of PROUD were very similar to those of IPrEx: HIV-negative gay men reporting unprotected anal intercourse with another man. And although the study was initially designed to look at risk compensation and behavior of people receiving PrEP or not, because in the deferred arm a few infections were documented early on, then the study was able actually to demonstrate efficacy. And indeed, when you look at the incident HIV infection in both arms, you could see that in the immediate PrEP arm, only 3 people became infected, as compared to 19 in those who received PrEP after 12 months. Only a few people actually developed resistant mutation, those who probably were infected at the time they received PrEP. Interestingly, when you look at the incidence of HIV infection in the deferred arm, you see that the incidence was very high, nearly 9 per 100 person years of follow-up, which is a very high incidence of HIV infection. Also, the efficacy was really high, 96%. This was an unprecedented efficacy with PrEP so far. And because of the high efficacy, the number needed to treat to prevent one infection was only 13. What I think interesting in that study was that of people 31, but still have in fact, post-exposure prophylaxis is probably not a very efficient way to prevent on the long term HIV infection in high-risk individuals. Because the study was intended initially to look at risk compensation or behavior, it was interesting to look at the rate of sexually transmitted infection in both arms, because people were expecting, if PrEP were to be associated with risk disinhibition, we would be expecting to see a higher risk of sexually transmitted infection in the immediate arm as compared to the deferred arm. And in fact, when you look at these data, there was a little bit higher risk of STI in the immediate arm, but this was not significant. And actually, because of a higher number of screen in people in the immediate arm, clearly these differences are not meaningful. And these data would suggest that, again, there was no evidence of risk disinhibition with early use of PrEP in the PROUD study. And this is an important piece of information which should reassure people that, implementing PrEP would probably not induce a disinhibition of risk in actually high-risk gay men. So let's spend now a few minutes on the IPrEx study. One of the reasons we conducted this study was also to try to provide high-risk people with more convenient regimen than a daily PrEP regimen if people have problems to adhere to a daily regimen. And the IPrEx study was really a study that was conducted from the beginning in close collaboration with the gay community, and in particular with the AIDS community group. So in that study, we randomized high-risk MSM with condomless anal sex with at least 2 different partners to intermittent PrEP with TDF and FTEC or placebo, and PrEP was taken before and after sex. The participants were followed every 2 months using 4th generation ELISA assay to detect HIV infection, to be able to detect primary HIV infection, and we also provided to these people the best preventive services that we could, including counseling, condoms, gels, testing and treatment for the STI, vaccination for hepatitis B and A, and also post-exposure prophylaxis. And that's the cartoon we use to explain people how to use PrEP for one sexual intercourse. So they would need to take 4 pills to cover one sexual intercourse, 2 pills before, in the 2 to 24 hours before sex, and this was based on data from the animal models generated at the CDC, and then 2 pills after sex, and the 2 pills after sex were separated by 24 hours. So over 3 days, people had to take these 4 pills. And as you know, the results were quite striking and very similar to those from PROUD, showing that after a mean follow-up of 13 months, we had 16 infections, 14 in the placebo arm and 2 in the Truvada arm. And actually the incidence in the placebo arm was also very high, nearly 7%. And the incidence was actually different from city to city. And in Paris alone, where we enroll half of the participants, the incidence was similar to PROUD in the range of 9%. So we also observed a 96% relative reduction of the incidence of HIV infection, and this was obviously highly significant. The 2 participants in the Truvada arm who became infected actually stopped using PrEP a few weeks, months before becoming infected, and they had no drugs detected in their blood, both at the visit at the time they were infected and at the visit before as well. It's important to say also that all people who became infected during the study were proposed to start immediate antiretroviral therapy, and all accepted to start ART, and they started ART a median of 6 days after diagnosis. And I think this is another interest of implementing PrEP, is to be able to diagnose HIV infection early and to propose and to treat people very early when they have HIV infection. And in fact, I didn't mention that, but when we screened participants to enter the study, the IPrEx study, 5% of the participants were actually not able to be enrolled because they were already HIV infected and they didn't know they were infected. So that's another benefit of this PrEP strategy, is to be able to reach people at high risk who may not be willing to be tested or to be tested frequently. And these people, because they are interested to receive and to have access to PrEP, will be tested and will be put in care. When we looked in IPrEx at the adherence of the regimen, we looked at adherence using different methods. We measured drug level in bloods, and we also measured the number of pills. When people returned their bottles at each visit, we counted the number of pills in the bottles, and we were able to show that on average people used 16 pills per month. If they were on a daily regimen, they would have to use 30 pills per month. So they use on average half the number of pills they would use for a daily regimen. And when you could see is the pattern of pill use, which was actually very similar in the Truvada and the placebo arm, which is expected in the double-blind study. And with the different colors, you have an idea of the number of pills used by the participants, and you could see that each line here represents a single participant, that over time the same participants could use different number of pills, probably according to his sexual behavior and also to the different partners with whom he has sex. And if you look at the first participants, for example, the first month he was using a pretty high number of pills, and then very few pills the next 4 months, then again pretty high number of pills, etc. So it was very difficult to show and to see a very consistent behavior, and clearly participants were using PrEP in the study on demand according to their use. Very important also is to look at adverse events, and clearly for PrEP, we hope that PrEP will be implemented very soon. It is critical for people to know that this regimen can be safe, and being in a placebo-controlled study is a very good way to look at safety of the regimen. And here, probably also because the regimen was intermittent, the safety was really good. Only one participant had to discontinue tenofovir FTC because of an adverse event, and this adverse event was a suspected drug interaction with anticoagulants, and we're not even sure that this was true. The only clinical adverse events that was most frequent with tenofovir FTC than with placebo were drug-related gastrointestinal adverse events when you combine nausea, vomiting, abdominal pain, and diarrhea. So we probably have to tell our participants, our patients, that they can expect to have some mild gastrointestinal drug-related adverse events, and we can probably help them to overcome this adverse event with all the drugs. Interestingly, also, when we looked at lab abnormalities, again, very few differences, although more participants had elevated creatinine levels of only grade 1. There was no evidence of tubular dysfunction when you look at proteinuria, glycosuria, and eventually no one has to discontinue treatment because of elevated creatinine plasma levels. And in fact, for those who had high creatinine plasma levels, it turned out that the majority of these people were on an almost daily regimen, and when we asked them to go back to an intermittent regimen, then the creatinine plasma level decreased. And actually, when I was talking recently to Bob Grant about one of his patients, he told me that he has the same problem, and a patient with a high creatinine plasma level in his cohort, he eventually put him in an intermittent regimen because he was concerned about creatinine plasma clearance. And eventually, the creatinine plasma level went back to normal. Also, in terms of liver toxicity, again, very reassuring to see no increase in ALT levels with TDF-FTC as compared with placebo, and actually those who had grade 3 or 4 elevation of ALT were people who had either acute HCV infection or syphilis. So in conclusion, what I would like to do is to highlight the major challenges that we have to face today with oral PrEP. And in green are the challenges which I think we can meet, and in red, those who are probably more difficult to meet. So we probably know how to support now long-term adherence to oral PrEP. We have the data from PROUD, which suggests that in people highly motivated, and you can have a high adherence to PrEP, probably also when people know more about the efficacy of PrEP when it's taken daily. For those not willing to take a daily PrEP, we know with IPrEG that if you take an intermittent regimen, and the data we have so far suggests that with 4 pills a week, it's probably more than enough to provide also a high level of protection from HIV infection. Can the benefit of PrEP be offset by risk compensation? Again, we have data from PROUD that suggests that it's not the case, and that providing PrEP to those at high risk, we will prevent HIV infection, and there is little risk of risk disinhibition. And actually, should there be a high, a risk of sexual disinhibition, this risk will probably not offset the benefit of PrEP clearly in those people. Can we avoid HIV resistance in people using PrEP? I think that this can be avoided also if we take due care to diagnose primary HIV infection before resuming or starting PrEP in people at high risk. What are the difficult challenges that we have ahead of us? Probably the biggest challenge is to make PrEP available to people most at risk. And just this morning when I was seeing my outpatients, I had 2 people who came to my clinic to ask me a question about PrEP, knowing that PrEP was not yet available, but these people were able to get PrEP from post-exposure prophylaxis in another hospital, and they were coming to me to ask a question about the way they should use PrEP. So there clearly is a need, there is an urgent need to be able to speak to these people at high risk and to tell them how to take PrEP and how to monitor PrEP also, because PrEP is a drug with Truvada right now, and we have to monitor people in terms of safety, and also to provide the better protection possible with PrEP, we have to tell them how to use it. Avoid PrEP's stigmatization. I think this is something we have to think about, and I would think that when PrEP will be more to overcome. One of the biggest challenges we have right now in France is how to deliver PrEP and monitor PrEP. It's not enough to have PrEP available. We have to train physicians and nurses to deliver and monitor PrEP, and we have to find the right places. In the UK, they had this nice GU clinic. We don't have such clinic yet in France. I don't know about other parts of the world, but clearly we have to think about places where we could deliver and monitor PrEP for those who would need to have access to these regimen. And finally, the cost of drugs is also clearly an issue, but I think really that cost-effectiveness analysis, which are ongoing, will all, demonstrate the benefit of PrEP according to the very high level of efficacy that we've seen in PROUD and IPrEx. So what are the opportunities today? Clearly high-risk MSM in Europe, that PrEP regimens are highly effective, and also they are very safe. So I think with these data, it's really time to make these PrEP regimen available to people. And to do that, we need also to mobilize the gay community and MSM at large, so that they are aware of the efficacy of this strategy to avoid HIV infection, and so that they will ask for this PrEP regimen, and they will go to their physician to have access to these drugs. Political support is key. I've been attending a recent meeting at WHO to increase testing in high-risk people and to provide early treatment for those infected. And clearly, combining PrEP and TASP and upscale testing should have a major impact on the HIV epidemic. And Bob Grant illustrated that very nicely at CROI, showing this graph in San Francisco, where when you have today 450 new HIV infections per year in San Francisco, if you can improve the viral suppression in those infected, you can decrease this number of new infections to 300. And if you can, on the top of that, provide PrEP to a large number of people, and if you can target 95% of those at high risk, you could achieve a very low number of the number of new infection in San Francisco. And so these strategy of combining PrEP, TASP, and improving testing also should have an impact on the epidemic, especially in high-risk group. And with that, I'd like to thank all the people who helped me to do the study. Clearly, the participants were still being followed in the study right now, and I'm happy to say that the efficacy of the regimen is still confirmed at this point. The study will be continuing until March of next year, and we hope that in the meantime PrEP will be approved in France, so that participants could then switch to a drug without being in a trial. We were lucky to benefit also for the study from the help of what we call peer counselors. We help people from the community, will help people to take their drugs, to do the counseling. The scientific committee of the study, the DSMB, we also had a community advisory board to help us with the study throughout France, because the study was not only done in Paris, but also in many other cities in France and in Montreal in Canada. And also the ANRS and the INSERM SC10, the clinical trial unit who lead the study, and the funders, ENRS, the Canadian Trial Network, the Bill and Melinda Gates Foundation, the Seed Action, the Fondation Pierre Berger, and Gilead, who provide the drugs and placebo. And I'll stop here. I'll thank you for your attention, and I'm ready to take any question.
Thank you very much, Jean-Michel. A very interesting presentation. And first of all, I know Sheena McCormack, the PI of PROUD study, is in the audience. Of Sheena, if you want to say something, please let us know through the chat window, and we'll make that possible. I also wanted to mention a couple of questions that I'm reading, or comments. One is, well, actually, comment from Mark Randall about what you said of people trying to get PrEP even if it's not available, and finding the way to get the drugs, because the information is out there, and I mean, it's an option they want, but it's not officially available. Then there's one question from Pedro. He's actually asking if you would say that PrEP on demand is somehow a combination of PrEP and PEP. That's one first question.
Is a combination of, I'm sorry,
of PrEP and PEP.
PrEP and PEP. Mm-hmm.
Mm-hmm.
Well, yes, I think PrEP, actually, we call that PrEP because we know we have to start before exposure, but it's clearly a combination of PrEP and PEP, but it's not PEP for 28 days. And that's also one of the interesting data from IPrEx. It gives you an idea of how long after exposure you can stop using PrEP. And that's a question that you don't have the answer from daily PrEP studies. With IPrEx, these data would suggest that as long as you're taking PrEP before exposure, if you're taking the 2 doses after exposure, after the last sexual intercourse, that should be enough. Mm-hmm. Meaning that you may not need to continue PrEP if you're not exposed for too long.
Okay. Okay.
Again, these data from IPrEx, we have to acknowledge that the data are limited at this point because we have only a few participants enrolled. Only 200 participants actually used intermittent PrEP in IPrEx. Right now, because the study is open label, we have more than 400 participants who are still using intermittent PrEP. And so we will also know more about how to use intermittent PrEP in the future, because more people will use it. And more people will be tempted to use it and will be comfortable to use it. And I think it's going to be critical to collect data from people who might get infected despite the use of intermittent PrEP to try to understand what went wrong. But as I said, at this time, right now, the 400 people are using intermittent PrEP, and at this point, we are very reassured with the efficacy we have seen in the double-blind phase of the study.
Okay, there's one question from Sheena, in fact, and she's asking, what would you recommend if people ask about taking PrEP for the first time? I mean, what would be your approach to it? What kind of regime?
Right. Well, I think again we should not oppose daily and intermittent. It should be a discussion between the physician and the person asking for PrEP, and we have to explain the benefit and the risk of each regimen. Yeah. And
So it's Sheena here. I've lost the sound. I don't know about anyone else, but the sound has gone again.
And each time you balance between regimen, might be more inclined to use a daily regimen. Should I repeat?
I think
can you hear me?
Jean-Michel, I heard some of that, but you broke up in the middle. So I heard you say, Sheena here, by the way. Great presentation. I heard you say that you shouldn't interpose the two, and then lost you after that bit.
Right. No, I think, you know, again, we have two options, I would say, today with Truvada for oral PrEP. You could use it daily, and you could use it on demand, and you know, for some people it might be easier to take it daily, for those easier to take it on demand, and that needs discussion with people. You know, obviously with on demand you would probably be on, a little bit safer in terms of toxicity, but on the other hand, if you're a little bit concerned about not being able to take the pills after sex and to adhere to the regimen which we used in IPrEx, then you might want to use it daily. Clearly, that's an individual decision, I would say. But at least we know we have the choice today. Mm-hmm. I would also acknowledge the fact that in IPrEx, we actually used intermittent PrEP in people at high risk. And although we assessed the strategy of intermittent PrEP, it turned out that people use PrEP quite frequently, because on average they use PrEP 4 pills per week. So, and these data, you know, are very consistent with the data from IPrEx, where they have shown that in post-hoc analysis, using 4 pills a week can achieve a very high protection from HIV infection. So in some ways, IPrEx confirms in a prospective double-blind study that this is true. Can we go beyond that? You know, future will tell.
But I was thinking, Jean-Michel, because so one of the advantages, I think, of talking about the IPrEx regimen first is that it really allows a conversation about people's specific risk practices, because you can't have that conversation about how they would use PrEP around sex unless you have a very clear picture of when they're having sex and what those risks are. And I think that's a very useful part of the conversation, whereas with the daily PrEP regimen, you know, when you start that conversation or when you carry on monitoring it, the oversight of the drug taking is separated from sex, because it's all about adhering to a regimen. So I do think there are inherent advantages in starting with the intermittent PrEP regimen, as well as the obvious advantage that there's less drug used overall.
No, I think we are just starting to learn about how to use it, because so far, you know, again, we didn't know whether it was effective, and we didn't know whether patients were using, you know, PrEP or placebo, and now it's really different, because we know that people, when they have to use on-demand PrEP, they have to think about, you know, their next sexual intercourse, what type of sexual intercourse with which partner, and you know, they put all these data in the equation to decide whether or not they should use PrEP. And it turned out that in IPrEx they made pretty good decision about that, except 2 of them who decided not to use PrEP. But it's not because they didn't want to use PrEP for a specific sexual intercourse. They just were tired of using PrEP. Actually, one of the participants was just tired not to know whether he was receiving PrEP or placebo. And it's going to be interesting to see what's going to happen in the open label phase. What I can tell about someone starting PrEP on demand is, you know, the question is, can this person be protected for the first sexual intercourse? And that's a question we don't really know the answer. You know, we can approach the answer by saying that that's what I was, you know, suggesting by some of the slides I presented today. In other studies, it's going to take a couple of days before you can reach a high level of tenofovir in PBMCs. Does that mean that this is the level that can protect you from HIV? We don't really know what's the level at at which you can be fully protected. But we can assume that. It was interesting to see in IPrEG that in the placebo arm, people were infected very early on, suggesting that intermittent PrEP was protective very early on. In animal models, you can protect the animals from the first challenge with HIV. So it's difficult to tell for sure, and we probably will never have this answer. And so we can discuss that, what's the best way to protect people. In any case, in IPrEG, with, again, the limit of the pretty small number of the participants we had, we haven't seen early HIV infection.
Okay.
I don't know if that answers your question, but it's probably the farthest we could go so today.
Thank you.
Yeah, very, very interesting discussion. There was a question from Anik, also from London, and she was asking whether there were any specific efficacy estimates for transgender women from either PROUD or IPrEG, but I think neither of those studies had transgender women at all, or I mean, not in a significant proportion, I think.
I can answer for IPrEG. We only had one transgender woman, so we cannot.
I'm afraid for PROUD also only one transgender woman.
Okay. Yeah, so definitely there's no information that we can consider.
But I remember when we tried to. When we tried to recruit transgender women in IPrEG, we had to discuss that with community groups also, and actually it turned out to be difficult to convince the community of transgender women to be involved in the study, because again, we didn't want to implement a study if the community was not comfortable with the study. And we had to advertise the study in the community, and it was actually, we had to stop to advertise in the transgender community because the community or some groups were not happy with the study in the transgender community. So that means that we have some work to do here to make PrEP acceptable also.
Okay, well, it's very interesting. There are also issues in San Francisco. For example, low adherence. There's concern about, at least from what transgender women say, potential interaction with hormone regimes, and but definitely a lot more needs to be said. There were a couple of questions. One is actually, I'm sure you have responded to similar questions in the past, Jean-Michel. Is about the choice for a placebo-controlled study, and what your impressions are concerning the effect that the use of placebo may have had in this study, as opposed to no placebo study.
Right. Well, again, that's interesting that we had the two studies, PROUD and IPrEG, one with a placebo, the other one without a placebo. Clearly, what we wanted to know with IPrEG was, first, was PrEP effective in high-risk gay men? What's the incidence of HIV in this community? And is intermittent PrEP something with a future? And that's why the study was, again, versus placebo, and clearly being versus placebo was a way to also be able to assess safety of the regimen, which is critical for people and again, being in a placebo-controlled study was, we wanted to show, the evidence of efficacy which could not be disputable, and we wanted to provide the best evidence that indeed PrEP worked. And now we have a different feeling about PrEP efficacy, but before that, Remember that we only had IPrEx, 44%, poor results, the results with PrEP. And so we just wanted to make sure that the study was conducted according to the highest standard in terms of clinical trials, just to be able to show the efficacy versus placebo of the regimen.
Okay, there's a question from Veronica. Is the demonstration project for IPrEx already planned and fully funded? When will it start? How many people will it possibly recruit?
So what we could say is right now the study is ongoing open label. And as I said, we followed initially 200 people for a median of 1 year. And now the study is open label for everyone. So we have 400 people because almost all of them are accepted to be followed in the open label phase. And this open label phase will continue until March of next year. And it started in November. So, so we will have at least a year follow-up in 400 people. So that will provide a number of information also. We also are thinking about another larger study in Paris potentially to try to do a project like in San Francisco or maybe in London also to see whether we can have an impact on the HIV epidemic using PrEP, TASP, and this is a much larger project, and we are starting to think about this project for 2016. But clearly, that would be a very costly project, and thinking about doing that at this point.
Okay, there's a comment from Claire Collins about the issue of transgender women, and she says that transgender women might be more open to being involved in PrEP studies if there is engagement prior to study. No, definitely that's, and in a way that's what you're saying, prior to study launch and recruitment phases, and that's definitely what you're stating. There's an Anik is asking if there is time. It would be interesting to hear more about the reasons transgender women refused to participate. What were their worries? Did PROUD experience the same problem? Like, I guess it has. Well, I don't know if there were clear reasons for transgender women to be concerned.
No, I cannot give you, explanation at this point. I can just tell you that we were very careful when implementing IPrEx to make sure that the community was comfortable with the study, because we had to advertise in the community about the study. And so it has been difficult to do the studies, particularly also because it was a placebo-controlled study, obviously. And so we wanted to be sure that the community would support the study, at least the majority of the community groups would support the study. And when we approach transgender groups, not all of them were, supporting the trial. So we thought it was probably not a good idea to impose the study, and that's why we stepped back in some ways. Although in the inclusion criteria, transgender women could be eligible for the study, we did not advertise the study too much in the transgender community.
Mm-hmm.
And Sheena here, if you for PROUD, I think it was just a question of the numbers. So we have in my own clinic, we have 6,000 HIV negative gay men attend each quarter, and I can't give you the number of transgender women off the top of my head that come, but it's certainly less than 100. Different numbers.
Oh yeah, that's completely true. That's it. In most places, it's a much smaller population. Mark Randall makes a comment. My experiences with clinical trials as HIV positive MSM is that the trial has to set criteria and pass ethics prior to recruitment and launch. Based on high risk for transgender, I would argue they should already be engaged based on risk for HIV infection. Yeah, we're getting close to the end, but I have I think an important point to make is probably the IPrEx findings are valid for MSM, and what you would say, and actually within MSM, if there has been any attempt to estimate difference in protection for receptive versus insertive anal sex, and probably for PrEP it's a relevant question too, and what I mean considerations do you feel should be held for, I mean, potential use in other populations, in heterosexuals, for example?
Again, it's a very good question. I don't have the answer, and I think we probably would need to do more studies, therefore, in heterosexual assessing this regimen.
Mm-hmm.
When implementing PrEP, you could also look at that and measure that. I think we have to be very careful, though, in the heterosexual population, because we don't have data at this point, and a number of phase 2 studies are being conducted by the HPTN network, looking at different ways of using PrEP, but these are not efficacy studies. So at this point, I think we have to be careful with intermittent PrEP in heterosexual people, because we don't have data.
Although, Jean-Michel, we do have CAPRISA. I mean, I appreciate that facts did not confirm CAPRISA, but we know that's for a good reason. I also appreciate that giving it topically achieves very high levels very quickly. But that was an intermittent PrEP regimen, wasn't it, in women? So I think that gives some hope that it would work also in women.
You're right. I think, we probably would need to move step by step, I would say. It would be important to confirm the data from IPrEx in a larger set of people, just to be reassured by the fact that indeed intermittent PrEP is effective. And when people will be reassured by that, then that might be assessed also in heterosexual people. But we probably would need to do studies before implementing intermittent PrEP in heterosexual people. Should PrEP be available for heterosexual people today at high risk, I would still recommend daily PrEP, but I would also recommend to assess intermittent PrEP in a study. It could be a demonstration project in heterosexual people, just to know also whether or not it worked, as well as in MSM.
And just to quickly answer for PrEP, the insertive receptive anal intercourse, we also won't be able to say very specifically, because overall, there are a relatively small number of events, and I don't think we really have we have recruited a tiny number of men who are exclusively top, but most people are top and bottom. What's interesting is that we were not going to include anyone who was top only in the PROUD study, but the community engagement group persuaded us that that was a mistake. They said that particularly under the influence of chemsex and Viagra, that people who are only top are sometimes actually exposed to HIV for much longer periods, because they're having sex for a lot longer, and so even though they may not be having the riskiest type of sex, they still could be exposed to HIV for longer, and it would be a mistake not to include them. So I'm very glad that we did let people in, even if they're exclusively top. So we can still say the eligibility criteria applied. What was interesting about the sexual behavior data is that we were very incomplete, we had a very poor set of data, but there was a suggestion of a slight shift towards more condomless receptive anal sex over the course of time. And this is a personal feeling from clinic and talking to participants, was that men became more confident about having receptive anal sex without a condom, particularly to ejaculation, because they accepted that PrEP reached very high levels in the rectal mucosa and was particularly protective there.
Mm-hmm. Okay, excellent.
Okay,
well,
I'm sorry, but I have to leave to attend another.
It's fine. Actually, we are past the hour, but I mean, this has been a wonderful discussion. Fortunately, it has been recorded, so I mean, you guys will be able to check on it. And I mean, as Mark said, it's a great discussion. We have to leave now, and really thank you very much, Jean-Michel, and also Sheena, for being here. And we'll, I mean, I'm sure we'll keep discussing this as probably some demonstration projects will come up, and other options of what is being called second generation PrEP regimes will probably emerge soon. So thanks again.
You're very welcome, and thank you for the opportunity to talk about our studies, and thank you for the discussion. It's always a pleasure.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you. Bye.